Okay, well, now last but definitely not least, we will hear from Dr. Rafidah Abdullah, consultant physician and nephrologist from Hospital Putrajaya. Dr. Rafidah graduated from University of Edinburgh in 1996. She then obtained her MRCP in 2001 and completed her nephrology subspecialty training in 2005. She trained in nephrology in HKL, Hospital Selayang, and Richard Bright Renal Unit, Southmead Hospital, Bristol, United Kingdom. Dr. Rafidah completed her Masters in Palliative Care with distinction at King's College London, UK in 2019. Dr. Rafidah also received many awards for excellence throughout her career in the Malaysian Ministry of Health since 1997. She is also a social media health practitioner with more than 500,000 followers across 4 social media platforms. She has had many abstracts and publications, delivered lectures at international and national meetings, and holds many responsibilities, including expert committees nationally and internationally. As someone who is very passionate about nephrology and palliative care, Dr. Rafidah will be giving a talk about addressing fluid balance in end-stage renal failure. Please welcome Dr. Rafidah to the stage.
Assalamualaikum. Good afternoon, everyone. Thank you, chairpersons, for the kind introduction. Thank you for inviting me to this wonderful seminar. Congratulations to the organizers for such a wonderful scientific program. So my topic for this afternoon is addressing fluid balance in end-stage renal failure. I do not have any disclaimer particularly for this talk. The objectives for today's talk are, number one, is to understand the role of palliative care in end-stage kidney disease. Secondly, to understand the basic principles in managing end-stage kidney disease with palliative care needs. The last but not least, the approach in maintaining fluid balance in end-stage kidney disease patients. And thank you so much to the organizing chairperson for allowing me to speak a little bit more about renal disease per se and how palliative care grows into nephrology. That would be the chunk of my talk, and subsequently we'll talk about fluid balance in end-stage kidney disease. As an introduction, many of you who have worked in palliative care field for many years is very familiar with cancer patients, but latterly we've realized that there are really unmet needs in chronic disease patients. End-stage kidney disease patients experience very high symptom burden, which is not relieved by dialysis. And end-stage kidney disease patients develop many complications and fluid overload and really pose significant challenges in its management. Just to show the graph, renal failure patients has poorer survival than some cancers like breast, colorectal CA. Renal failure patients has reported disability in the last year of life. The problem with organ failure patients, the trajectory is unpredictable, as many will know, and it's so difficult to manage. Sometimes I would argue it's more difficult than managing a terminal illness such as cancer. Just to outline what the options are for chronic kidney disease patients, it has more than 276 million patients who has chronic kidney disease worldwide. And end-stage kidney disease is close to 10 million. I'm sure it's more now. Not all patients are suitable or able to receive dialysis treatment for whatever reason. Of course, dialysis is hemodialysis and PD, peritoneal dialysis, and the other option would be the better option is transplantation. And not forgetting now, becoming more and more, is the comprehensive conservative care. Just where all this fit, this is the framework for integrated kidney care for low and middle income country. Malaysia is an upper middle income country, and I believe this framework is not far from what we need in Malaysia. We should run away from talking about HD or hemodialysis. We should be talking more about kidney transplantation and have more kidney transplant, work towards that. Focus on improving or increasing peritoneal dialysis. But for those patients who do not have options of kidney transplant, we should be talking more about conservative care. And of course, crux of everything will be delaying and preventing progression of kidney disease. That should be the focus of our management day to day. So go back to the definition. End-stage kidney disease is the last stage of CKD when kidney replacement therapy could be considered to improve longevity or quality of life. Throughout the CKD journey, patients will need supportive care. And supportive care per se, it holds the principle of palliative care. Definition is well known to all of you. Improving quality of life to patients and their families facing life-threatening illness through prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of the total pain, not just the physical, but the psychosocial and spiritual as well. In terms of comprehensive conservative care per se, it is where conservative care is chosen or medically advised. It's either the patient is not fit to have dialysis or is chosen by the patient themselves. This is a planned, holistic, person-centered care, and it's not just not to give any care. In fact, arguably, it's more difficult than giving dialysis. So it comprises intervention to delay progression of kidney disease, shared decision-making, managing symptoms actively, really communicate well, including advanced care planning, psychological, social, family supports, and look into the cultural and spiritual domains of care as well. Needless to say, whether you dialyze the patient or you do not dialyze the patient, our renal failure patients really have a lot of symptoms, largely under-recognized and undertreated, obviously. This is a conceptual framework for those already on dialysis many years down the line from the presentation of illness. Dialysis patients will need more and more palliative or supportive care rather than a curative or remittive care. This is when, as dialysis physician, when I see a patient going into that last year of life, I would shift the goalposts not to achieve high standards of dialysis care, but more towards the patient-centered metrics, what is best for them, and really focus on symptom control and the goals of care. In terms of goals of care and advanced care planning, advanced directive is not legal in this country, but it doesn't stop us from talking about advanced care plans. So we should be talking as nephrologists every step of the way, from the CKD journey, once they develop end-stage kidney disease, and also once become unwell and they going towards the end of life. Palliative care consultation, if it's done early in the management of kidney disease, is really, really good. It has many, many benefits. But the question is how feasible that would be. We as nephrologists should take that responsibility somewhat, because we are the ones who manages the patient from the beginning and towards the end. Every step of the way, we need to support them, whatever decision they make, whatever social, emotional, spiritual, informational support that they need, and we should be able to control the symptoms as well. Along the way, we as clinicians should be able to give some sort of supportive care. It is recommended for renal physicians to have some sort of knowledge in giving primary kidney palliative care. We should be able to do symptom management, the basic ones. We should be able to make decision-making, and we should have a team to support us. And obviously, we as nephrologists should be well-versed in conservative care, which is non-dialysis therapy, and do it well so that patients really do not have to change their mind at the last minute. I'm always in the opinion, if the patient changes their mind, it's probably number one, whether the decision was not the right one in the first place. And secondly, whether we are not good enough to actually control the symptoms. So let's go to the second half of the talk when I talk about the fluid balance in end-stage kidney disease. Basically, there's not much evidence out there specifically tailoring for fluid balance for those patients who has palliative care needs. So how do we maintain euvolemia? Well, if you're not for dialysis or patients not undergoing dialysis, it really depends on the overall clinical fluid status. The main important thing is to educate the patient, to prevent, and really empower your patients to actually make the right decisions in terms of what they eat or what they do. how much they drink. I'm not a person who tell, you've got fluid restriction, 500 ml, 800 ml. I don't do that in my care. I usually tell them, look at your own body, feel yourself, weigh yourself regularly. The main thing is to control the salt intake, really reduce the amount of salt in the food. It's difficult not to eat salty food in Malaysia. And if you eat outside, literally everything is salty. But what I say is you eat outside less frequently. It's very difficult to say you can't. And of course, choose the right food. Those ones in the cans and all that, obviously it has a lot of salt, and I always encourage them to check the food labels. In terms of those patients on dialysis, you get referrals from this kind of patient who is reaching the end of life. But those patients on PD has less fluid restriction than those ones on hemodialysis, because hemodialysis is done 3 times a week, whereas PD, you're doing every day, and you have extraction every day. That is why PD has a lot more benefit than hemodialysis. So in terms of food, it's very, very difficult to control, to be honest with you, especially thirst. End-stage kidney disease patients, they are really thirsty. Most of the time, like for example, we give them lots of tablets as well. Sometimes I don't really blame them. What are the tricks or the tips that I always tell my patients? Of course, when we give them iron tablets, they'll be constipated, right? So I usually actively ask them if they're constipated. Obviously, they think they're dry, they eat it, you drink a bit more. Change your diet a little bit, put more fiber in it. Perhaps if you're constipated, just stop the iron. Not worth it, really. So these are some of the tips and tricks that I tell them. I said, look, divide your fluid to small amounts. If you want to take regularly, if you're really thirsty all the time, use smaller mugs, half fill the mugs, the cup. Drink between meals. Caffeine-free drinks are much better, because if you drink caffeine, you'll probably be a bit more thirsty. Now I would say sip rather than take one shot at a time. Maybe take medication with food, or cut down the medication, which ones are unnecessary. And a lot of guides suggest ice and things like that. I'm not a fan of ice, because if they take ice, it's just going to take more, and it's quite a lot of fluid if you actually take ice. So I would say, not too hot, but sort of in between. So prevention of complication is the most important. But once they develop complications, which is literally fluid overload, but rarely they are under volume, unless they are unwell, they have sepsis, they have acute or chronic kidney disease that need a little bit of fluid. Most of the time, the problem is actually fluid overload. Fluid overload in kidney disease is a very strong predictor of death. Abnormal fluid status is associated with high blood pressure, heart failure, left ventricular hypertrophy, lung congestion or pulmonary edema, and of course pedal edema. So how do we look at the patient? Well, clinically the blood pressure is high, they are tachycardic, some of them really bad pulmonary edema or congestion, they get hypoxia. And clinically, when you do chest examination, you hear crackles, sometimes you have abdominal ascites, and you have pedal edema. So to confirm that, we do a chest x-ray, the heart will be big, you have cardiomegaly, and the ones which are bad, you have fluid in the lung. Of course, there are various, what we call advances in medicine, where you can, have a machine and actually calculate what your so-called dry weight is, how much fluid you have extra. We call it body composition monitors. It's not available everywhere in every unit throughout the country. The mainstay of treatment is actually diuretics. A lot of patients that you see, they're already on some sort of diuretics. The most common is actually the loop diuretic. Yeah. So the main ones is furosemide. Most of the time, furosemide needs a really, really high dose. And if it doesn't work, I do like bumetanide, but again, it's not like freely available in government clinic kesihatan. What about thiazide? Well, I would say it can be given somewhat. It does have evidence, especially in heart failure, fluid overload, and so on. Metolazone, which again is not freely available everywhere, but I quite like that drug. And of course, stop unnecessary medications. I would stop all these spironolactone at this point because, hyperkalemia is difficult. Just an example of what we do. I mean, I'm thankful that I work in IKN where they've got a wonderful palliative care department who helps me in managing end-stage kidney disease patients by visiting them. And this is a patient who's she's had to stop her job to look after her mother. She's doing assisted peritoneal dialysis at home, and for I think a year and a half now. And the mother had fractured neck of femur, and following that, she's bedbound. And the picture when I'm wearing blue was the picture last week when I met the daughter and her. She's already going downhill. I changed the approach to a palliative approach, which means I cut down the 4 exchanges to 3 exchanges. Now I don't do bloods anymore, and things like that. So the daughter and the patient understand that, they are nearing end of life, but it's not easy. The patient needs psychological help, and the assistant, which is her only daughter, needs a really psychological help because they both have really bad depressive symptoms. So what are the challenges? So many challenges to fluid overload. As you know, diabetic kidney disease is #1 cause of end-stage kidney disease in this country. Trajectory of the kidney function, obviously, the ones that I usually see is that #1 here, which is the classical trajectory. Once developed proteinuria, they develop end stage fairly quickly, and once they are very badly nephrotic, they have nephrotic syndrome, where they really have fluid overload. Another challenge that we have in Malaysia is our patients present very, very late. They present when they're already ill. If they present late, obviously fluid overload is a main issue here, and obviously these patients don't do well, even poorer survival in 6 and 12 months. We all want to achieve integration, right? We all want to achieve some sort of standardized treatment nationwide. When I looked at how we should standardize this, how we should do this, even at the primary care level, there's so many areas we need to improve in nephrology, and the main thing is in that structure which I show here, that needs to be there. The pre-dialysis education to the patient and the families needs to be there, needs to be done well, so that they can make informed choices, make proper decision making, and they're empowered to decide what's best for them. For that, Ministry of Health have worked with NGO, pharmaceutical companies, professional societies to have a website, the www.mybuapinggang.com. We do mention a little bit about non-dialysis therapy there, and we have something a bit more detailed, which is the pre-dialysis education program, PDEP, for those patients who's nearing stage 5, stage 4 and above. So there's a lot of room to innovate. Just finally, before my conclusion slide, this is something I started recently, which is home hemodialysis. This is a wonderful lady, ex-engineer, who already been on hemodialysis for about a year and a half, and she developed stage 4 lung cancer, and she fractured the head of neck of femur and pelvis, and because of that, she's bedbound. It's very difficult to stop dialysis, obviously, in this kind of patient because they're very alert. They know what's going on. And treatment or chemo will get them, at least a few more months, if not a year-ish. Stopping dialysis will make them die within 7 to 8 days. So I decided to not rock any boat, but to start her on home hemodialysis. And I hope we would like to expand the service to those in need. And as conclusion, ladies and gentlemen, I hope I've shown you that palliative care plays a huge role in integrated renal care. Treatment of end-stage kidney disease really need to be individualized. We all need to move forward towards performing person-centered care and shared decision-making. Supportive care needs to happen throughout the CKD journey, and that holds the principle of palliative care. As I mentioned, fluid overload is one of the main complications of end-stage kidney disease, if not the main complication, and maintaining of euvolemia is important if you want to not have too many symptoms towards the end of life. Dietary modification, fluid restriction, diuretics really is the mainstay of treatment. And of course, the most important thing is actually prevention of that fluid overload, by proper education, proper changing of lifestyle, proper diet, proper medication, things like that. Before I end, I would like to say thank you to every single one of you who help us to look after renal patients. And I really, really hope you could continue. We will have more sessions in terms of training personnel on renal disease per se. We hope to do that a bit more, next year with NKF, within KKM universities, so that you could join any of that. You're more than welcome. I really look forward to working together with every single one of you. Thank you for listening.
Thank you so much for that, Dr. Rafidah. Now, a significant number of our patients are certainly end-stage renal failure patients, including where I work at Kasih Hospice. Now, we'll have questions for all the panels, so we're going to move on now to the Q&A session. Please feel free to put your questions in the Q&A box or in the comment box on the right.